Hello, and welcome to In Service of Health, brought to you by the Public Health Accreditation Board. This is the podcast that brings healthcare and public health leaders together to inspire new thinking for healthier populations. In this episode, I'm excited to sit down with my good friend, Dr. Megan Ranney, emergency physician and dean of the Yale School of Public Health. Dr. Ranney is an accomplished researcher, violence and injury prevention expert, public health advocate, and clinician. We talked about a range of issues, the intersection of public health and healthcare, the importance of effective communication, data democratization, and the role of multiple sectors in advancing public health. I hope you enjoy the episode. Dr. Ranney, friend Megan, thank you so much for joining us on the podcast. I'm just so thrilled to have this conversation with you. So I appreciate you taking the time today.
It is absolutely a pleasure, Dr. Khaldun. I've known you for an awfully long time now, and always a joy to have an excuse for a conversation.
Exactly. So let's just jump right in. Tell us, I know you, but tell our audience a little bit about what motivates you to do this really important work that you do.
So I entered the world of medicine and public health in some ways back as a high school student, but really made a distinct choice to go into this field after 2.5 years in West Africa as a Peace Corps volunteer after college. I was in Côte d'Ivoire or Ivory Coast in the late 90s at the height of the HIV epidemic, at a point when antiretrovirals were not yet available in Africa. In fact, WHO was doing trials at the time to test whether or not folks in West Africa could take them. That made me want to come back to the US and get trained in medicine and then eventually in public health, in order to both be able to treat the folks who I loved, who were getting sick and dying because they wouldn't get tested, and then if they did get tested, couldn't get treated, but also because I wanted to change the systems and structures that kept them from having equitable access to treatment. Then, as you know, went into emergency medicine, which is, as one of my friends says, where all policy goes to die, but where we serve as the canary in the coal mine for all of the public health problems of the globe, that really heightened my resolve to work in public health, and eventually led to my taking this dean position at Yale School of Public Health because of my commitment to not just doing research on the issues that I care about, but also enabling a school and a generation of folks to do great research, to be educated in creative ways, and most of all, to be empowered to go out and do the practice that we desperately need, both in this country and across the globe, to change those systems and structures that determine health.
Yeah, thank you for that. And, you touch on, again, you and I met many years ago. I think we had both just finished our emergency medicine residency programs. And we found ourselves similarly wanting to advance policy, research, interventions, particularly around violence and injury prevention. My first kind of public health love for sure. But for me, I'd love your perspective. What I recall most about that early time in our careers is that we were often the only or one of few physicians in these spaces where there were kind of people who had traditional public health backgrounds, PhD, MPH, which I found, a lot of fun. I thought it was great. And I think what I recall, again, this is going back many years, we won't tell folks. But you and I quickly became friends because we understood this intersection between public health and clinical medicine. I think it was just natural for us, and quite frankly, I think for a lot of ER docs. But let's talk a little bit about that. Let's talk about, what is this intersection between public health and healthcare, right? And how can public health and healthcare work better together? And maybe even for those who may not understand what public health is, you can just say a bit about that as well. So what is public health, and how does public health and healthcare work together?
Yeah, so I frequently talk about, medicine. I'm working at the bedside on behalf of an individual patient. Public health, I'm thinking on a population or community level. I may still be thinking about systems and structures for an individual, but right, we do individual, family, neighborhood, and then all of society. And so that to me is the big difference, is the scale at which we're thinking. Am I trying to diagnose and treat on a one-on-one basis, or am I thinking about the systems and structures that got that person sick in the first place? I think there are two ways in which public health and healthcare has a lot of space to grow in its intersection. I think we have been separated really since the Flexner report, but then certainly since kind of the revisions to payment schedules in the 1960s with the professionalization of medicine, the idea that medicine is all about that individual per patient payment. Changed a little bit with value-based care, but still thinks of changing systems and structures just on behalf of an individual payment. I think that one way in which we can come together is to train folks together. I think that we need to have more MDs who have MPHs. We also need to have more MPHs or PhDs who have some experience or exposure to that clinical world and to understand the pressures that physicians, nurses, pharmacists, social workers are under, so that we understand each other's worlds and can think better about how those systems and structures can intersect. So that's one thing that I think is missing, is the way that we've been professionalized and the way that honestly we're paid has resulted in us being competitive and very, very separated, even when ideas of public health are brought into medicine or when ideas of medicine are brought into public health. We don't speak each other's language and don't get exposed to the same things. Relatedly, the second part to me that I think is a huge area for us to lean into is around data. We are both collecting data on the same people and looking at it and then duplicating each other and then using it for very different purposes. And I think that if we could join forces on some of that data collection, again, I think this goes back to some payment issues, right? So like a nonprofit hospital has to do a community health needs assessment. Meanwhile, their state or local, their city, county, or local or state health department has probably already done the same thing or some part of it. How do you join those forces together and then use it to inform, again, joint programming rather than competitive programming? I know some of the 1115 waivers that some states are using have helped that, but I would love to be able to move more of that out of the remit of one versus the other. The last thing I'll actually say, though, and this isn't about places where I see either separation or intersection. I think that the lack of intersection between public health and healthcare explains some of the factors that lead our clinical colleagues to tremendous burnout. Because I will tell you, and you know this, when I am working a shift in the emergency department, I am expected to not if I am a good empathetic doctor, my heart is going to be tugged on by the fact that I can't get someone with COPD air conditioning, or that I can't get access to good food or reliable access to insulin for my diabetic, or that I can't change the safety of the streets that someone is going to be sent back onto. I think, and I can't be asked to be a social worker or a public health professional when I'm working on that individual medical basis. I think we are asking far too much of clinicians and putting far too much on the burden of healthcare systems simply because we haven't created alternative ways to pay for and integrate these systems. The founder of my school, CEA Winslow, said back in the early 1900s that he was creating the Yale School of well, it wasn't called the School of Public Health at that point, but he was creating our program because he believed that we needed to integrate prevention and clinical care. And somehow we've unfortunately, since that early time and the Flexner report, moved too far away from it. So I think there's an incredible moment right now for us to think differently about how we integrate those two functions, the population and the individual.
Yes. Oh my gosh, there's so many nuggets there that you dropped. I do want to get into data in a moment, but I also want to dive a bit more into, again, my favorite topic, which is just this intersection between clinical care, especially, again, we're both practicing ER docs and clinical medicine. So what do you say? This is my favorite argument. Now we're going to get a little hot here. So this is my favorite argument to have, or conversation, I should say, not an argument to have. This sentiment that, you're a busy ER doc, When you're in the ER, again, I just worked a shift this weekend, so I get it. But you've got to take care of the sick patients. You've got however many people in the waiting room. You're struggling with emergency department boarding, which is only getting worse. You have multiple medical students and residents to supervise. Again, we get it. But at the same time, we know that for many people, the emergency department may actually be the only place where they're touching the healthcare system at all. And it's likely the only place where they're going to be able to get certain interventions or engagement. And we also know that it's probably going to get worse as more and more people, millions of people, are slated to lose their Medicaid over the next several years. Not to mention, as you know very well, our health departments, our CBOs, et cetera, are seeing dwindling resources and funding. So I like what you said about we need to change our systems and structures. I see that as a long-term kind of absolutely. It's messed up. We're getting the outputs that come from the inputs.
Yeah.
But let's talk a bit about, and I know you're an expert in this, about like what are the interventions? What do you say to that clinician or that healthcare administrator or the ED administrator? Like, yes, we can't fix everything, but are there evidence-based public health interventions within the confines or context of the emergency department that people can at least try that can move the needle a bit from a public health perspective?
Yeah, absolutely. I mean, I think so there's a few things. One is that there is tons of data at this point around let me actually moderate that statement. There is a lot of data around screening people for social needs and then linking them out to community-based resources. The trouble is that sometimes that works, sometimes it doesn't. And in fact, there was a large study showing that an electronic linking system increased the number of referrals, but didn't increase the uptake of services. So something that I would love to see more healthcare facilities do is to not just screen and refer, but also to actually partner with those community-based organizations. I'm going to use an example here of the work that I do around violence prevention. If you have a community violence intervention program who's out in the community and has no relationship to the hospital, and you have someone who's been hurt, that puts them at higher risk of being hurt again, you call them and say, hey, follow up with this person. Chance of that person ever actually getting the care that is indicated from that community violence intervention program is quite low. On the other hand, if I have a partnership and my healthcare facility helps provide some financial support, a badge, some access to the electronic medical record for that community organization, they can come to the bedside, they can meet the patient, they can intersect with them, and then they can be that warm handoff that then follows through, and there's a much better chance of them actually engaging. I think we need some similar creativity, whether it's around food banks, whether it's around shelters, that's not just let me hand you a piece of paper and send you off into the wild, or let me create an electronic referral, but let's create systems and structures where there's true warm handoffs. That's one thing. And again, we've done it also for opioid use disorder. We have similar examples. But it's a space that I'd love to see us lean into more, and not, again, put it all on the already overwhelmed clinician.
Exactly. That's right. Just build that connection. I love it. On that topic also, you're an expert also in leveraging digital tools and technology to advance public health interventions. Talk a little bit about that and what you've seen actually work to improve outcomes.
So the idea behind digital health, when I started working on it, 15, 20 years ago, was that it was a workforce multiplier, right? We know that we don't have enough folks out there to serve as therapists, to serve as to do follow-up, to check in on medication adherence. And so it would be a workforce multiplier. And then, of course, there's the idea that it is instantly accessible to everyone. Even 15 years ago, 97% of our emergency department patients had phones and were interested in technology-based interventions. So the concept was we can do all these things that we know that we need to do and do them more efficiently and reach more people through technology.
Yeah.
There have been some examples of places where digital health has been quite effective. Pear Therapeutics was a great example of a private company that had data to support that their digital interventions supported adherence with treatment, for example, for opioid use disorder. The trouble is twofold. One is a lot of these digital health interventions show great results in little pilots, and
Hmm.
then when you go try and scale them, kind of fall flat. The other is that there's not a lot of digital health companies that have really figured out how to pay for their product in a way
Yep.
that creates sustainability. And unfortunately, even Pear Therapeutics, which had good data behind it, did end up folding because of that challenge around funding. I still believe in the potential for digital health as an augmentation of physical touch, right, or physical kind of human
Yeah.
experience and connection. But that funding challenge and then the efficacy challenge are not ones that I think the field has fully met yet. I'll go though again. There are some. Lyra Health is one that is
Yep.
doing well and surviving. So it's a space that I think there's a lot of possibility right now. We will have patients find their own ways to get digital health, though, if we don't provide it.
That's
We're
right.
seeing it with AI chatbots right now.
Yep.
We're watching people flock to social media for information, whether or not it's been validated. So
Yep.
I do think there is an onus on us to lean in to make sure that our friends, family members, and communities have good digital access to care. And but we got to figure out those payment models.
Yeah, I appreciate that. And it's a good segue into something else I wanted to talk about with you, which is trust, right? So you're talking about like where are people going? They're going to places they trust, and it turns out it happens to be an AI chatbot often, or grandma or whoever else. You were certainly you're always a powerhouse, but you were certainly a powerhouse and just a really trusted communicator during the pandemic. We also know that the field of public health in general um, lost the trust, not of everyone, but of many people, because of some of the ways in which public health leaders communicated. I won't blame public health, but there are many things, context there, of course. But I think there's certainly an opportunity for improved public health communication. And at the end of the day, we have a trust problem today. So how do you think about really building that trust in public health? What's working well, and what do we need to do to improve?
Yeah. So it's interesting. I think when we talk about the COVID pandemic, I think, there were some ways in which public health recommendations got misunderstood,
Hmm.
misapplied, became too dogmatic, particularly as the
Yep.
pandemic moved on, often in response to politicization
Yep.
by others. I think a big part of the problem, though, is that, when I talk to public health professionals, right, we get trained in in one goal, which is so actually infectious disease epidemiologists or virologists are trained in minimizing transmission of
Yep.
an infection. There's a whole host of other considerations out there, and I don't think that we necessarily consistently train people in that crosstalk that policymakers, that you, Joneigh, lived and breathed during the pandemic, right? And that ability to say, okay, we have to think about decreased transmission, but we also have to balance it against these other metrics. And in the state where I was living at the time, Rhode Island, Gina Raimondo did, I think, a great job of balancing those, got us, our kids back to school with the advice of public health professionals in fall of
Yep.
2020. And
Yep.
state, my kids were in public school in
Yep.
September of 2020 and stayed in school. So I push a little bit against the demonization of public health. I think we were not set up to do this
That's right.
well, and I think
Exactly.
those, and I think, but I do think there's some part of training. Okay, so that's part one. Again, there are mea culpas to be made, and we need to consider the evidence of public health in the larger context of
That's right.
policy. Part two, when you ask about how to create trust, we are now in an ecosystem in which media sources are atomized.
Hmm.
Trust is based off of relationship rather than based off of expertise. So I say that we go back to the basics.
Yeah.
When you and I sit at a bedside of a patient who we've never met, how do we create trust?
That's right.
We do it by listening,
Yep.
right? And by not dismissing
Yep.
the very real concerns of the patient sitting in front of us.
That's
Do we
right.
succeed with every patient? Absolutely not. But do we have a better chance if we come in and sit and respect their reasons for coming into the emergency department, their concerns, their barriers? Absolutely. I think the same thing is true for public health. And I will say at Yale, we are proving that point right now through our engagement with a number of communities, whether urban or rural, red or blue, who have been traditionally distrustful of public health, all the more so post pandemic and all of the
Right.
unrequited grief that we all went through, the trauma that we all went through for those 5 years,
Hmm.
3 to 5 years. We are actively recreating that trust by listening at the start and engaging communities in co-creation of solutions that matter for them. And so I think that there's a big step back that we all have to take around listening before we can move forward into kind of anything else. I think
Right.
we all our entire society forgot how to listen over the
Right.
course of the last 5 to 10 years.
That's right. Yeah, I appreciate that. First, seek to understand, right? And sometimes when it's, but people are dying, I just need you to do this thing, but that doesn't resonate with folks, right? You gotta listen and meet folks where they are. That's just kind of how it goes.
But Joni, I think that's exactly the exact analogy. Like when I think about, if I have a acute resuscitation, I'm just
Yep.
going to do the thing. Like I'm not going to listen.
Yeah,
And that's
that's
where
right.
we were in the earliest days of
Exactly.
the COVID
Exactly.
pandemic. But then as we moved from March, April, May
Yep.
into July, December, the next
Yeah.
July, we forgot that that's the moment where you have to step back and listen.
That's right. That's right. And there's context, right? Not to go along with the ER analogy, but like, yeah, maybe you need pressors right now, but maybe like later on you just need to like titrate, whatever. Get your
And,
fluid,
and have a discussion about goals of care. Like,
Exactly. 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 Again, some of our listeners are probably like, what are they talking about? ER docs speak here, but I get it, and you're absolutely right. There's a way, there's a time, there's a place, there's a context to everything. So I
yeah.
appreciate that. Uh, let's talk a bit about go back to data, right? You are doing some pretty phenomenal work on data, democratizing data at Yale. Tell us more about some of that work and what is the challenge? Just set up the issue, the problem actually, which you touched on a little bit earlier. But what's the problem with data, access to data, and what's some of the work you're working on?
Absolutely. I mean, gosh, problems with data are legion. So just to say it outright, data is the foundation of anything that we do in public health, right? It is how
Mhm.
we decide what problems to work on, where to work on them, and it's how we evaluate whether or not our interventions, whether policy, individual level, right? It's how we evaluate whether or not our interventions are making a difference. The trouble is that many of the traditional data sources in this country are either super delayed, right?
Yep.
It takes 2 years. We do surveys every 2 years. We get vital statistics data that's delayed by a year to two, depending on kind of what you're talking about. So either very delayed, and so therefore makes it difficult to respond in real time, and or is incomplete, right? We're missing a lot of
Yep.
data, both from specific locales and around specific conditions. So we have two big problems that we're facing. We, of course, saw that during the COVID pandemic
Mhm.
when the Atlantic set up that great COVID tracking project, which we all relied on for our counts of
Mhm.
hospitalizations and deaths because the CDC didn't have the infrastructure and the data use agreements in place. So we at Yale, about a year ago, said, gosh, this is a problem that people have been talking about for a long time. What if we tried to fix it? And can we do something different in academia than in government? Because maybe we can partner with private organizations who don't want to share their data with government. Maybe we can get the trust of states that don't want to share their information with the federal government because of concerns about privacy, right? We're not selling anything, we're not regulating anything. Why don't we try? So we've worked over the course of the last year, and I will give huge credit here to my colleagues, Ann Zink, who is a senior fellow with us,
Yep.
and Dan Weinberger, who is a professor of epidemiology of microbial disease. The two of them have taken this project, the bull by the horns, and have worked tirelessly to bring new data streams in, harmonize our definitions of different types of health problems, and
Mhm.
then create national maps that you can go down by state, county, and in some cases by zip code for emerging problems, respiratory diseases and their incidence and frequency of visits to the emergency department, for example, but also chronic or acute diseases, obesity, diabetes. We will soon have some injury diagnoses as well. Next step is maternal morbidity and mortality. To create these new multi-source maps that hopefully will improve trust and reliability, but help both healthcare providers, policymakers, and local communities to understand how common health problems are, and then make decisions about what they want to work on and what they want to keep investing in. Because anything you do is money and time that you don't have to do something else. So that's really the solution that we're coming up with, and hoping that it will address one of those things I talked about earlier around the disconnection between healthcare and public health. Hoping that it solves that kind of lack of crosstalk in many, not all, but in many locales between healthcare systems and public health.
Yeah, and you're spot on. As a recovering local and state health officer, oh my gosh, trying to respond in real time, like you're seeing, signals that folks are dying, whether it's opioid overdoses, RSV, whatever. But you go to your whether state CDC government website, it's like, oh yeah, 2 years, we gotta wait. It's like, I don't have time to wait. People are dying.
Right.
And so, yeah, that's
So
right.
for those who are interested, Joneigh, the website is pop,
Yeah.
like population, hive, like a beehive. So pophive.org. And it's maintained by us at the Yale School. It's a project of Yale School of Public Health, but in partnership with lots of folks around the country, Carnegie Mellon, Google, Epic, much more. Really, really grateful for our partners and for our funders. It is not federally funded. I welcome input and new data sources. Always happy to chat with folks.
Yeah, thank you. PopHIVE.org, and we'll also make sure this is in the show notes. So thank you. So let's also touch on, you've talked about burnout a little bit. So let's touch on the workforce. And of course, you have your finger on the pulse of public health professional students as a dean. What are you seeing as a dean as far as the workforce and up and coming students who are in public health or excited about public health? How are you? What's the sense you're getting on the ground? It's been a rough year, to say the least, for folks in public health. Well, what's the current landscape, but also what inspires you to do this work every day?
I mean, it's been a rough 5 years. Even pre-pandemic, we knew that the public health workforce, like the medical workforce, was burnt out, insufficient. People were retiring early, right? This has been a problem for a long time. It got a bunch worse over the pandemic. And then, of course, the last year with a lot of reductions in force and unpredictability of funding has been even tougher for those out there on the ground. And I hear that every day. I feel it in my bones. It hurts my heart on behalf of public health and the communities that we serve. At the same time, I also hear within my school and within my recent alums a sense of optimism and agency. I will say, the students that graduated last year were stuck in a particularly bad moment. Many of them did have job offers rescinded. But I will tell you, most of them went and got other jobs. And one of the things that I'm hearing that I think is terrific is creativity around the spaces and places that public health needs to work. I'll tell you, Joneigh, we declared a new vision for our school just about a year ago. It got unveiled late last fall. A vision of linking science and society, making public health foundational to communities everywhere. And in that vision, I frequently make the point that we developed it as a school community, both people currently and formerly within it. I make the point that public health is not all about government public health, right? It is about making sure that the skill sets, the discipline that we learn, the way of measuring and then addressing health problems should be foundational to communities everywhere. It should be part of urban planning and architecture. It should be part of media. It should be part of tech companies. It should be part of consulting. And our students are going on and doing that. I mean, the breadth of places that our students are working as graduates of the Yale School of Public Health. Of course, many of them are still going into government or into clinical care or into law, but the breadth has just expanded tremendously in the last couple of
Yeah.
years. And that is actually the way that I think it should be. Because just as we don't think of a law as being something that only belongs to people who are in government legal profession, right? Like
Mhm.
who are in civil service. Similarly, I don't think we should think of public health in that way. It is a public good, and it needs to be integrated into the work of Fortune 500 companies just as much as we need a governmental infrastructure to make sure that there are some, food safety, for example. Right, we're going to need food safety
Yep.
inspectors, and that probably has to be in government. But many of those other kind of aspects of public health need to be integrated into all of society rather than segmented off and kind of put in this little box, which I think is it's an opportunity for us to lean in.
Absolutely. I 100% agree. Public health is really about what we collectively do, right, to advance the health of society. Governmental public health has a really important role, of course, and there's things that governmental public health can do that others cannot, and dare I say, should not, yes.
Mhm.
And we have to think about this broader ecosystem. I mean, you touched on your work in Africa and kind of the intersection between healthcare and public health. I've certainly, I've worked in a Fortune 10 company, and it's like, I don't know, I was just doing public health. It didn't seem odd to me. And so you're absolutely right. Can we really think about how we can all work in different sectors to advance public health, which is what we all really, really want. So final question. Uh, what is one, and I feel like you've given so many like tips and tidbits throughout our conversation, but what's one actionable tip, resource, piece of advice you'd recommend for our colleagues who are listening, who are really striving to bridge this kind of public health and clinical medicine intersection and to really think upstream?
Oh, that's interesting. Um, well, sign up for our Leaders in Public Health series
Uh-huh.
at Yale School of Public
Yeah.
Health. We have a Zoom version as well as in person. I bring folks in just about monthly to talk about kind of new ways of thinking about this intersection. I
Yep.
would, of course, encourage folks to come and get a master's,
Yeah, yeah,
whether a master's in science or master's in public health, to understand the structures and systems,
yeah. Yep.
to understand the scientific methods, but also to understand that creation of trust.
Yes.
Um, for that, but now I'm going to give you a funny third thing
All right.
that is actually a huge part of how I am maintaining agency and optimism
Yeah.
and a long-term vision at this
Mhm.
time of kind of chaos, which is to read history. You know,
Yes.
when you asked me about the separation between public health and healthcare, and I went back to the 1910s, I could
Hmm.
also talk about things from the 1800s or the 1700s. And I will tell you, I have been finding solace, but also inspiration
That's
in
right.
reading history right now. The history of the 1980s, read And the Band Played On.
Hmm.
Um, Read about work around smoking cessation or car safety. Read about the social creation, the Paul Starr's books about American medicine, but also read about Jefferson and read Team of Rivals about Lincoln and read books about like the French Revolution. I think it all is just so helpful to us as we try to put this moment in context to inspire us, but of course also get that training in the science if you don't have it.
Yeah. I love that. I love that. And it's such an important point that I've also leaned into is like some of the things that are happening today is really a bit of history repeating itself. And it's a little bit of it is human nature and, and how we kind of move forward as society and sometimes a little bit backwards, but it's almost expected, dare I say, if you know your history.
Yeah.
Well, Dr. Megan Ranney, thank you so much for joining us. It is always a pleasure to have you on, and I know folks will enjoy our conversation.
Vice versa, Joneigh. It is such a joy to be here with you. I am so proud of you and all you have done with your career. When I think about when we knew each other quite a few,
Here we go.
decades ago, and the things that you've done, whether as a state and county health official, whether at that Fortune 10 company or now in this position where you are literally influencing the health of all Americans. I'm just really grateful for your leadership and for your voice. It is a true honor to join you today.
Oh, you are so kind. I'm looking forward to getting into good trouble together.
Here's to
Continue,
that.
continuing to. All right, thank you.